Guillain-Barré syndrome, a care plan for 18 to 65-year-olds by Alex Norton, RN, BSN. The etiology of this disease is still not completely understood, but it is understood some common causes that have been associated with individuals contracting this disease. GBS presents most commonly following specific infections and vaccinations. Common infections it's been associated with are the Epstein-Barr virus, Mycoplasma pneumoniae, HIV, cytomegalovirus, and most commonly associated with Campylobacter jejuni. Common vaccinations that are associated with the development of GBS include rabies, influenza, oral, polio, diphtheria, tetanus, measles, mumps, hepatitis, and smallpox. Gender and age considerations. Guillain-Barré syndrome is seen in 1 to 2 people per 100,000 individuals. This is most commonly diagnosed in individuals who are in their 40s, and it seems to be more prevalent in men than women in a 3 to 2 ratio. Pathophysiology. This disease causes peripheral neuropathy, which results in effects to both the peripheral nerves and the cranial nerves. This is due to the fact that this disease process occurs after the body has produced antibodies following a vaccination or infectious disease, which results in the macrophages of the inflammatory response invading the myelin, which leads to demyelation of the axons. However, this is not completely understood. Some common signs and symptoms would be ascending bilateral weakness or tingling beginning in the legs and moving in an upward fashion to the arms, paralysis, and respiratory compromise. Cardiovascular interventions. Due to paralysis, patients are at high risk for the development of DVTs and PEs. These individuals need to be on a DVT prophylactic such as heparin or Lovenox, wear sequential compression devices, or compression stockings. These individuals also have a decrease in blood volume due to their immobility, which will result in orthostatic hypotension. Utilization of tilt tables and changing positions slowly is necessary until the patient can maintain and tolerate an upright position. These individuals are at high risk for cardiac arrhythmias due to central dysautonomia, accounting for 31% of deaths related to complications. 70% will experience sinus tachycardia, sinus bradycardia, hypertension, or hypotension. Close cardiac monitoring is necessary to address medical emergencies. Respiratory interventions. Due to progression of paralysis, the respiratory system is affected, resulting from demyelination of thoracic muscles, a decrease of the gag reflex, and involvement of cranial nerves. 30% of patients will develop respiratory compromise and require mechanical ventilation. Close monitoring of respiratory status is essential, and interventions should be addressed early to decrease mortality rates. Bowel and bladder considerations. 11 to 30% of individuals will develop urinary retention due to autonomic dysfunction. Sometimes urinary retention can be a presenting symptom, however, this is less common. This must be managed with an indwelling catheter to prevent complications such as bladder distension. This will usually resolve as a person recovers from this disease. 17% of individuals will develop constipation, leading to development of an ileus. Implementation of a bowel regimen can decrease their risk for an ileus. Reproductive considerations. There are few reported cases of pregnant mothers diagnosed with GBS. However, those who are have a higher mortality rate associated with pregnancy specifically. Recovery for these expectant mothers takes a lot longer compared to other individuals. There is no evidence to suggest fertility issues will be a problem later on in life related to this disease process. Endocrine function and interventions. GBS is associated with extreme fatigue due to the effects on the hypothalamus. The hypothalamus, which is part of the endocrine system, is involved due to GBS's effect on the neurological system, which is located in the brain and part of the nervous system. Approximately 80% of people affected by GBS reported extreme fatigue, more commonly in women than men. Therapies and activities must be spread out, and a lot of time must be allowed for rest periods due to severity of fatigue that is experienced. Neuromuscular system interventions. Neuromuscular system works with the neurological system to coordinate movements. Due to paralysis and weakness, these individuals develop muscle wasting. Extensive physical and occupational therapy is necessary for optimal functioning in day-to-day activities. Gastrointestinal. Gastrointestinal system affected due to cranial nerve involvement leading to swallowing difficulties. There's a decreased ability to protect the airway, and these individuals are at higher risk for aspiration. Many of these patients will require intubation. Patients will need supplemental nutrition due to their inability to swallow. Once these individuals are stable, speech therapists will be consulted to assist with swallowing needs and to help with their abilities to communicate. Cultural considerations. There are 4 subtypes of GBS. The first type is acute inflammatory demyelinating polyradicular neuropathy. The second type is acute motor axonal neuropathy, acute motor and sensory neuropathy. The third type is Miller-Fisher syndrome, and the fourth type is chronic idiopathic demyelinating polyradicular neuropathy. AIDP is the most common type of GBS. It accounts for almost 90% of the cases in North America and Europe. This type is characterized by ascending motor and sensory neuron loss. Acute motor axonal neuropathy and acute motor and sensory neuropathy accounts for approximately 3 to 5% of the cases in developed countries. However, it accounts for 47% in less developed countries, including China, Japan, and Mexico. This subtype most commonly seen following Campylobacter jejuni infection. This is characterized by a severe and rapid onset of symptoms. Miller-Fisher syndrome accounts for only 5% of cases. Determining characteristics include oculomotor dysfunction, absent reflexes, facial and bulbar paralysis, and ataxia. CIDP accounts for 3 to 4 cases per 100,000 people. It is characterized for its chronic relapsing symptoms, which include weakness, sensory loss, paresthesia, absent reflexes, and cranial nerve involvement. Modifiable risk factors. Campylobacter jejuni is the most common infection known to lead to the development of GBS. Risk. Primarily, C. jejuni is spread through the oral-fecal route, common in areas of poor sanitation systems. This is spread by improper preparation of food, eating behaviors, cooking methods, and meal conservation methods. Some modifiable interventions include education on mode and route of transmission, the teaching of proper hand washing, especially after using the restroom and with food preparation, teaching the importance of cooking foods to a specific temperature to rid bacteria, and the demonstration of safe ways to store food properly and safely. Non-modifiable risk factors. There are many factors that individuals have no control over. Underdeveloped countries do not have resources necessary to prevent spread of infections. GBS is unpredictable, and individuals are all different in how their bodies will respond to various infections and vaccinations. The disease process is not fully understood, and there is not a lot to do or ways to predict the development of GBS. Some primary interventions include education on the importance of hand washing, education on how infections are spread and ways of decreasing incidences. Proper hand washing and safe food preparation can help decrease the spread of infections. There are not many preventative measures due to this being an autoimmune disease. Secondary interventions. Throughout this presentation, under each body system are interventions that should be implemented. A treatment option a patient can undergo is plasma exchange or plasmapheresis or immunoglobulin therapy. Immunoglobulin therapy is the primary choice for treatment, although both work in similar ways. It is administered IV and works by decreasing antibodies. Plasmapheresis removes patient's plasma, which contains immune complexes, and replaces it with fresh frozen plasma or albumin. Tertiary interventions. 80% of individuals make a full recovery within 2 years of the illness and do not have deficits. 15% will have lifelong deficits and have difficulties with activities of daily living. Intensive physical, occupational, and speech therapy are essential. Many patients require inpatient rehabilitation until they are able to. Technology. Electronic health records and the utilization of power plan order sets to be incorporated specifically for GBS care plans can help increase patient outcomes and verify that specific actions and interventions are not missed. A power plan order set is something that can be ordered specifically related to disease processes and make sure that based off of evidence, all necessary interventions along with all necessary interdisciplinary personnel are involved with this patient's plan of care. Conclusion. In conclusion, it is important for healthcare providers to have an understanding of GBS and how it affects the various body systems. A multidisciplinary approach is necessary due to the complicated nature of this disease. With collaboration by a multidisciplinary team, there is an increase in outcomes and quality of improvement in patient care.